get started.
You want to start with the thoracic?
Oh, yeah.
Yeah, okay.
Are you comfortable, sir? Lay still, okay? Just lay still for me. How's blood pressure? Yeah, let's try to get that down.
Yeah, I think it's 3 volts.
Whatever you need to do, I want it to be lower.
You want this or?
Mm-hmm. Yeah. All right. So we're going to be broadcasting the surgery live, and our patient will have the video as well afterwards. I'm just feeling around, okay? Shot. 12, 11, 10. Let's go with a lateral view. Are you in any pain, sir? I need you to relay what he said. Good. You're going to have to do... Shot. All right. Well, let's see. That is, let's go back to an AP. I think we're a bit overexposed there. Okay, Jordan? We need to fix that. Shot. All right, so probably too medial. Shot. And that's 12, 11, 10, 10, 11. That's where we're supposed to be. Let's go back to a lateral. So we're right at the facet joint. Cables. And Sean. All right, let's try to line up the 10-11 disc a little better. It's not much. It's about a degree of wag probably. Maybe some orbit. I think it's, yeah, try that. So there's really no point in going further until you're happy with your views. That's pretty good. I think that's, let's try something with the wag. Feel like we can do a little better on the wag. So the first thing we need to do is have reliable navigational information. That's good. Let's leave it at that. Okay, reliable navigational information. Shot. So that's what I'm looking to get. Yeah. Shot. Shot. He's doing good. This is a more uncomfortable part of the surgery, so. Shot. I feel like the pedicles aren't lined up somehow. Just give me the wag control. Shot. That seems a little better. Let's lock that there. Actually, wait. He does have some scoliosis. Let's go the other way just for a second. Let me just verify. Shot. We've got an orbital issue. Let's bring maybe your side down a degree. Let's see what happens there. Shot. I can't tell if that's worse or better. I think that's worse. Let's go the other way. Shot. That's definitely better. Definitely better. That looks good right there. Let's lock that in. Shot. So I'm really close. I'm on the facet. Shot. You're doing great. Just lay still for me, okay? Alright, so I need to go a little bit more lateral. Shot. 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 You're doing great. Just keep nice, even breathing. You're doing fantastic, okay? Shot. Shot. What? You feel it? Yeah, you're gonna feel it. You're awake. Shot. All right, let's get an AP. I believe that's 10-11 disc. We're supposed to be on the left side of 10-11. We are, because the herniation's off to the left side on the MRI, and the patient's symptoms are worse on the left side at 10-11. So let's verify. It looks good. Give me south a little bit. Perfect. So I just want to make sure you're a little too dark on the image. Let's lighten it up, and then let's just rotate the top south, because I want to see the rib connecting, the T12 rib connecting to the pedicle. I want to see down the disc, basically. Other way. Try the other way. Yeah, I'm not sure what we need to do. We may have to go further down, but let's just try to find it. What do you think? I mean, does that look better? Worse? Play with it. Shot. What are you thinking, Jordan? Worse. All right. That's okay there for a second, but we can definitely see the T12 rib. We can see the T11 rib. We can see the T10, and we are at 10-11. All right, let's come and bring this side further south. Let's just see what that does. So I feel very confident we're at T10-11. All right, let's go with a lateral view. You okay, sir? And we are doing T10-11. We're all in agreement. We are at T10-11. So for those of you watching, this patient is having pain up here at T5-6, down here at T10-11, and then at here, 3 discs here. Just relax, breathe nice and smooth. Shot. Give me a better shot. Yeah, it's hard to see, but are you comfortable? Just don't tighten up. You're doing really good. Just relax. You're doing awesome. That's your first disc. All right, we found it. So, there is no place else in the world you will ever see this surgery done, because this is a posterolateral transforaminal thoracic disc repair. And the only thing other surgeons even have that's close is to cut this whole thing open, expose the spine by peeling all the muscles and ligaments off, and then doing a laminectomy and fusion. Lay down. Okay? Otherwise, I'll strap on my sterile saddle. Are you comfortable? All right, so the nice thing is now we know where T1011 is, right? So we got a marker for 5-6. So we can count up from our position where we currently are. Just lay still. Blood pressure is looking better, but not perfect yet. All right. I want to see, so T5-6, I'm going to want to see the first rib. So 10-11, 10-9-8, 7-6-5. 5-6, right? So let's go ahead and just let's stay where you are for a second. You okay, sir? You're doing great, by the way. Just lay still, okay? Shot. All right, so move north just 1 inch. All right, there it is, I think, right at the top. Let's see what I can tell based on the anatomy. Let's go another inch. Actually, go north a little bit. All right, so if that's 10, 9, 8, 7, 6, 5. You all agree? 6, 5, 5, 6. So I'm right at the pedicle of 5. And we are doing 5, 6 right side. That is the right side. So yeah, let's go up to that disc now. And I will target it and we'll verify the location. So if you're doing spine surgery at all, you have to get really comfortable using this machine called the fluoroscope. And the fluoroscope is basically a mobile x-ray machine. It moves. All right, so I'm thinking it's the level below, because I'm at the pedicle of 5, we said. So I need to see, I need the table up perhaps, or the fluoro down, one of the two. All right, so I think we need some wagulation. I think our orbit's not bad, but our wag could be better, I think. I want to see down that 5-6 disc space. I want to see it open up. So the thing about, it's the other way. The thing about x-rays is they shoot a beam of radiation that's straight, like a straight line, basically. And as it comes out, it kind of spreads off center. Okay. So what we really want is a straight shot down the disc, and to get that, you have to line the center of the X-ray beam up with the disc. Can we do better? We may need a slight amount of orbit. It looks like we're offset on the superior facets of 5. So try some orbit first. Let's see if we can correct that, since that's easier to see. I think that did it. It did it. I think that did it. I think you need to be further north. Are you able to do that with his arms? Doctor, keep an eye on his elbows, please, and the fluoro. And let's keep that blood pressure down. All right. That's actually pretty good, Jordan. Pretty darn good. So I think that might work for us. Let's see. Shot? Shot? I think I might want to come slightly lower. Let me have the local. Take this. Actually, I'll keep it. Are you comfy? Oh, and our patient's awake. Unlike massive thoracic surgery done at the hospital where they're going to fillet the patient's back open just to fix one disc, our patient's awake, so we give him some, sedation a little bit in the beginning. Eventually, we're going to put him completely to sleep. But you really have to visualize three-dimensionally. And we have something special about this patient. This was my first thoracic patient. And I did his surgery in 2020. And unfortunately, he's re-injured himself. And so we are now actually fixing additional discs that we didn't fix last time. Are you comfortable? All right, let's get the fluoro up a little higher. I don't need that much of the lung field. I just want to know if you're comfortable. I'm comfortable. Are you comfortable? I think we can fix the orbit. You see the little rabbit ears at the back of the disc at 5/6? It's just a slight orbital change. At most, maybe 1 degree or half a degree. Let's just try it and see what happens. I can't tell if that's better or worse. Can you? Huh? All right. I think we're fine right there. Let's just leave that. Shot? Shot? I need to be a little bit lower. I think I'm going to just reposition this a little bit lower. And in this game of spine surgery, millimeters matter. Shot? You have to be millimeter perfect. You have a question for me?
Yeah, we just got a question from Facebook. Has Dr. Duke performed the combination of thoracic and lumbar before?
That's a great question. Have I ever done a combination of thoracic discs and lumbar disc repairs at the same time on the same patient? The answer is yes. Yeah, I mean, there was a year ago, I would say no. I wouldn't even dream of it. But the reality is that some of these patients, they don't want to have two separate surgeries. All right, we need to fix the orbit. I'm looking at this pedicle and I'm thinking we're just off a little bit on the orbit. So yes, I've done it before, though. I've probably only done a couple, like 2 or 3. Okay, let's see what we got there. I think it's worse. Let's go the other way. Yeah. I think that's probably as good as we're going to get. Maybe a slight improvement. I can see a double shadow at T5. Let's see if we can't fix that. So slight more orbit. A little more. I don't know if we're going the wrong way. What do you think? Worse? Better? I think it's better. Huh? It looks better, right? So that helps actually, because it shows me my position before was probably the right position. So what I would say to people who want to do spine surgery or endoscopic surgery, you must get really good at reading x-rays. Okay, aiming too high. Because the x-ray is your guide. If you don't know how to read these x-rays properly, you're going to end up hurting somebody badly. So you have to have a really good understanding of X-ray anatomy of the spine. And unfortunately, a lot of doctors don't. Shot. They're trained to use the X-rays, or read them, but they don't read at the detail, three-dimensional anatomy level you really need. Shot. So I'm aiming for that T5-6 disc space. Are you comfortable, sir? As comfortable as you can for having surgery done on you while you're awake, right? So I was inspired, let's get an AP. I was inspired to do awake surgery by my colleague, neurosurgeons, my fellow neurosurgeons, because we were doing awake brain surgery on people, and I realized, shoot, if we can do brain surgery on people and take out tumors while they're awake, well then we should be able to do spine surgery while patients are awake, right? Yeah. Let's go back to a lateral, please. Let's see where we are. So we started doing awake spine surgery and these types of procedures about 15, maybe 15 and a half years ago. I did my first endoscopic awake surgery. And as I tell everyone, I learned from the Koreans and a German surgeon and an American surgeon. Are you comfortable? Just keep the dialogue to a limited. I just want to know if you're comfortable. All right? If you're uncomfortable, I may have to give you some more medicine to make you more comfortable. Shot. All right, so we're at the end plate, and I want to make sure we're at the right level. So let's do an AP again. Okay, so we're ready to go into the disc. We're in the foramen. You can see the tip of the needle is there, and I'm going to verify where I am. So the way I'm going to do that is I'm going to count from the top down and from the bottom up. I'm going to do it both ways because it's too important. You want to make sure you're in the right spot. So let's go north. Good. Shot. All right. So I believe that's a T5, 4, 3, 2, 1. And there's your first rib right there. You see it? So the pedicle of 1 has the first rib. Let's go a little further north. Actually, we're fine. You can see the pedicle of T1 on both sides has a rib coming off of it. So T1, 2, 3, 4, 5, 6. We are at 5, 6. Now let's go down and count from our needle at T10, 11, and we'll count up. So when it comes to doing spine surgery, there's, you must navigate properly. And there's two parts to this X-ray navigation deal. Number one is, that's good. So that's 10, 9, 8, 7, 6, 5, 5, 6. So we are right where we're supposed to be. There's two things to X-ray navigation, or to using an X-ray in the operating room, okay? It's called image guidance. Number one, navigation. You have to navigate from the outside world to the spot you're trying to fix safely to avoid vital structures and make sure you get past everything without harming the patient, which we've done. And then number two, you need to localize. And what localize means is make sure you're at the right spinal level, the right disc. So you got to count the bones because the discs are the cushions between the bones. So I'm making sure, looking at the X-ray, that I'm at the right disc. If you operate at the wrong disc, you're not going to help the patient. So it's important that you operate at the right disc. Are you comfy? As comfy as you can get, right? Shot? So he's moved a little bit, but I think we're still okay. Shot. Sorry about that. I wish there was a more painless way of doing this, but you're doing fantastic, by the way. Does that feel like it's in the area where your pain typically is? Just say yes or no. Oh, you can't feel right now? What did he say?
What is something poking in my chest right now?
Something poking in my chest.
I don't know what it is. There's something down there.
Is it on your skin?
Something in my chest, right in the middle of my chest right now. This is looking very painful.
In the middle of my chest.
Yeah, but that just started, right?
No, it's been going on for a while.
Huh?
I've been going for a while.
Is it something you're laying on, or is it something I'm doing to you?
Something I'm laying on, doctor.
All right, we need to figure out what he's laying on that's poking him. Is he on a lead, like an EKG lead or something that's uncomfortable? Is it on your right side or your left side?
In the middle of my chest.
In the middle of my chest.
All right, there should be, he's on a gel pad, right? Gel rolls?
There are pillows.
So he can't slide his hand down the middle to feel what's down there, like by the xiphoid, or you have to come from the side?
Yeah, he can. Yeah, he should go to the side. Yeah, he can go through the middle because the EKG leads are on the back. Yeah.
All right, so what could be in the front? You still feel it?
What is it at the level of the sternum? At the level of the
Is it above your belly or below your belly?
make sure it's above your not exposed too much. I'm gonna put my hands slightly. And if I
Let's keep an eye on this.
Yeah.
So, because our patient's awake, he's a little bit uncomfortable. We want him to be comfortable.
Lower.
So we're going to go ahead and get him comfortable. Let's go ahead and place. He's talking nicely, breathing nicely. You're not short of breath or anything, right? Huh?
Where is my finger is? There's nothing there.
It could be a little bit of referred pain from the facet being a little irritated. Injection.
Where I put my hand and he said yes.
There's nothing there. Okay, good. I just don't want to get a little decubitus or anything like that. Okay. You're doing great, sir. Everything is going better than I expected it to, okay? All right. Let's come down here and figure out where we are. So we're going to do 2, 3, 3, 4, 4, 5 on the left side. We are on the left side. Everyone agree? 2, 3, 3, 4, 4, 5, left side. So there's 5, 4, 3, 2. All right. Just lay still. Everything is fine, okay? Shot? Did you give him something to make him more comfortable? Uh-huh. Just lay still. We want to keep him cooperative, though. Shot? That's amazing. So there's nothing there. Go north a little bit. Let's see if there's anything there. Just a slight bit. Lay still. You're doing great. Not too much for set. I want him cooperative. Come on, Jordan. All right. He's just got a deep back. It's amazing. Shot. You're doing great. Just hang out. 5, 4, 3, 2. So we need to go a little bit lower. One of the nice things about our patients here is they all get to watch their surgeries afterwards because they like watching the surgery, not during the surgery, but actually after the surgery. So we've given a total of about 15 mils of local. Watch the needle. You're doing great. Just relax. We're going to have you asleep soon, but I need you awake for a little bit longer. You're helping me tremendously to do the surgery safely. All right, so what is that? 2, 3, 5, 4, 3, 2. Did he get some Versed?
Yes, I give him total.
Yeah.
He's still awake, breathing.
You're fine. No, we want to keep. Yeah. So I know we haven't done a lot of these surgeries together, doctor, but the one thing with thoracic we worry the most about, I'm not worried as much about spinal cord injury as I am pneumothorax, right? And we've not had one, but that is a risk of the procedure. You're doing great. Just lay still. Shot. So 5, 4, 3, 2. That's good. That's good. Yes. You're okay. Let's see if we can get the 3, 4 lined up a little bit better. You're fine. What's he saying? Just lay still. You're doing great. Come on, I need you to get a better picture than that. You got orbit is off by about 1 degree. Your wag may be off as well. It may not. I can't really tell. Shot. I can't tell if that's worse. Let's go the other way. I could tell because of the superior facets of L3. Sorry, L4. Is he okay? Come on, Jordan. All right. Why is the clarity so bad? Are we doing something different? 5, 4, 3, 2. All right. Numb. I need numbing. Just lay still. I'll give you more numbing medicine. You're doing fine. All right, you got the cervical scope and the lumbar scope, right?
Yes, sir. But my question for you is,
I don't know what I'm gonna do yet. Shot.
you call.
You're fine.
In that case, they can bring it. In that case, you can stay here. 8:46 or 8:45. Fuck you.
Shot.
Or 3 up.
Did you say pack you or something else?
3 up, I said.
I thought you said fuck you. All right.
I just need epi.
Shot.
Epinephrine. Should be there.
That's better.
Should be there in this line
So there's
with epi.
5,
You'll be working with epi.
4, 3, 4 is there. Shot.
And an 18 gauge, please. Yep. And 18 gauge.
Shot. AP. Okay, so once again, I'm Dr. Duke-Majan, and it is August 18th, 2021. And you're watching, if you're watching today on August 18, 2021, you're watching a live surgery, what's called a live stream. And we're actually broadcasting our surgery live, nice job, around the world over multiple platforms, including YouTube, Facebook, and Twitter. And we're going to be adding LinkedIn soon because Diego noticed that LinkedIn is beta testing a live stream platform. Good job, Diego. This patient is having surgery on his back because basically he has what is called disc herniations. And disc herniations are the little cushions in the spine, and they get injured. And when they get injured, people can get pain in their back or neck, and sometimes they have no pain at all. But everybody's a little bit different, and every disc herniation is different. Are you awake? All right. So I've got to get this positioning needle in. Let me wag a little bit. I think I need 1 degree. It might have just moved. Shot? Can't really tell. It just seems a little blurry to me, doesn't it? Right? It's not just my imagination. Shot? And I can't tell if that's a wag or what. I think that's good right there, but we need to change the orbit by 1 degree, and I don't know which way. Try one way, then the other. I'll try down. All right, go ahead. Go ahead. Again. So what I'm emphasizing to people that are watching, that's good, is there's no point in advancing your needle if you don't have the right fluoro shot, because you will be going somewhere where you really don't know where you're going. You won't be able to see your target properly, because remember, the spine is 3-dimensional, but your image is only 2-dimensional. So you have to reconstruct it in your mind properly. Shot? Are you still comfy? There we go. Just lay still. You're doing great. Any pain? Where? Huh? Just say back or leg.
Whatever you want.
Yeah, okay, just the back. So we've accessed 3-4. Let's verify that by looking at the sacrum. And you have to count from the sacrum up in the back, in the lower back, when you're operating in the lumbar spine. You want to see the sacrum. See the sacrum down there, that solid piece of long bone? And then the first disc space is L5S1. We're not treating that, but the one below, above that is L45, and the one above that is 3-4. So we have accessed the 3-4 disc, which is the middle of the 3 discs in the lower back we're doing today. You okay? We're going to make a little incision. We use a 7mm incision. Okay? And this 7mm incision, we're going to fix 3 discs. I want you to compare for a moment a 7mm incision versus the incision we would have to make to do a open fusion surgery to fix his back, which is from about here all the way down to about here. Okay? That's how big the normal incision would be. Now we're going to be fixing the L3-4 disc. And that's a cushion right there. The L2-3 disc there, and the L4-5 disc down here. Okay? So this is L2-3, L3-4, L4-5, and then up here we're fixing T10-11. These are with the Duke laser disc repair. That's the name of the procedure. And T5-6. Okay, so nobody in the world, no surgeon would ever fix all these discs at one time, except for at Duke Spine Institute, where we do minimally invasive endoscopic surgery. So this patient is getting the benefit of having one surgery to fix everything. All right, let's look at 2-3. And I don't normally do so many discs because most people don't need it, but there are some patients who do. It's about 10% of the patients we see need 4 or more discs fixed in one surgery. But about 90% of them need less than 4. So needing more than 4 discs repaired in your spine is unusual and rare, thank God, but it does happen. Okay, we need a little, you see the orbit, right? Nice job, Jordan. Jordan, you're getting to be an expert here. I love it. I think it's the other way, perhaps. Just lay still. We're going to have you asleep soon, okay? I think it's worse for some reason. I don't know. What do you think? I see a double that's better. Let's try something. Maybe it's better. Maybe a little bit more in that direction. That's probably as good as we're going to get it right there. Let's leave that. All right. So we're targeting L2-3 now. You're fine. Shot. So you're starting to look like a Ouija doll. Huh? Whoa. I know. The good news is you're getting it all taken care of today with one surgery. But you're going to look like a porcupine or a Ouija doll. Okay? Some people may think I'm cruel and insensitive, but the truth is humor is a good way to approach stressful, uncomfortable situations, as long as it's not inappropriate, which I don't think it is. And if you do, you can just fuck off. Yeah. Yep. That's what happens when you get to produce your own show. You get to actually control the content. Since I'm paying for it, you don't have to watch it. All right. Sorry about that. I know it's a bit uncomfortable, but we're almost there. So we are targeting the L2-3 disc. You can actually see something there. That is not inside the disc, believe it or not. That is outside the disc. You're fine. Shot. All right. You're fine. That is outside his skin. It's a, maybe that's the button he's talking about. What do you think?
No, he said on the chest, just like that.
This is around L2-3. I don't know what those are, but they're not inside his body. You didn't have buttons put in your body, did you? By somebody? Huh? It's his gown? Interesting. Well, I mean, I thought our gowns, do our gowns have metal buttons? Well, that wouldn't be the back. That would be in the front. Is there any way to get gowns without metal buttons?
We have two different ones.
Huh?
One without.
Okay, listen carefully to me. Get rid of the metal button gowns. You understand why? We use a bovie. What do you have to do with a patient before you can take them to surgery and use a bovie?
No, remove all the metals. Usually when we use
You have to remove all the metal.
Yeah, usually
If those are metal buttons and they're up against the skin, they can get a burn. Yeah, we haven't had that happen, thank God, but yeah, we have to get rid of all the gowns with metal buttons. I don't want to see that. I mean, I don't mind strings, but that's it. No metal buttons, period. Okay, that's right up against the skin. We're not using a bovie today, but God forbid if we were, could be a problem. All right, so one of the things about live streaming is you get to see everything that happens in the operating room, good and bad, and we want people to. We want people to see the truth. That's our mission, is to educate the public with the truth. There's so much misinformation about spine surgery and spine care, and we want to eliminate the misinformation. Shot? All right, so let's see if I can get us down to where we need to go. You're doing great. Just relax, okay? I don't want you to worry at all. Let's fix that wag. Uh-huh. Shot. That's actually better. Still a little higher than I want to be. Shot. Still too high. Shot. Oh, what'd you do there? That's definitely better, but shot. Are you comfy, sir? Shot. We're gonna have you to sleep soon, okay? Oh, you're okay. I promise. Oh, it's beautiful. Any pain? Where? Where? Nothing down the leg, right? But nothing down the leg.
Nothing down the leg, all in your back?
All right.
No pain in the leg. All in my back.
Where? Where? In your back or leg? Just the back? Where? How far down? All right. Very good. You did good there. You helped me. Sean? I may have to do another incision for this last disc because this incision is a little higher than I want it to be. All right? Sean? I don't think I'm going to make it. Shot. I'm going to give it one more Boy Scout effort. So I'm trying to reach the L45 disc, which is the last one we're going to treat, through the same incision as L23 and 34. And normally I can do that, but everybody's anatomy is slightly different. Shot. And if I can just do one incision, it sure would be nice for the patient, but if I can't, I can't. Where? In your back? Just the back, right? Huh? Yes. We did it. Wow. Look at this, guys and gals. This is incredible. You'll never see this done anywhere else in the world. No one has the ability to do it. We're going to fix 3 herniated discs in his back through a 7mm incision. Then we're going to fix a thoracic herniated disc causing him horrible pain. Your back pain is up here, right? And then we're going to fix another thoracic herniation, all in one surgery, all within 2 hours. And it's going to be outpatient. Are you comfy? Are you comfy? All right. No pain? Okay, good. I'm glad to hear that. I couldn't get it. We need to go further up. Can you pull my skirt up a little bit? The skirt I'm referring to is a leather skirt. I mean a lead skirt, not leather. Oh God, leather skirt. Lead skirt. Sorry. Because a little higher. I thought I tightened it good, but it just wants to creep down. That's good enough, thanks. Good enough for government work, right? All right, is that our thoracic? Upper thoracic? Yes? How bad is that on a scale of 1 to 10? Huh? Is that where you typically get your pain? Yes or no? Is that where you get your pain, that location? That's the upper one, right? Correct? Is that the upper pain you typically get? Yeah, okay, good. So that's concordant, 10 over 10. Are you documenting? So 10 over 10 and concordant. Okay, so we just tested the T5-6 disc, and you can see there's a leak and it goes out around the nerve root in the foramen. So we've done a transforaminal access through the tear in the back of the disc. There's a little tear. This one has a tear here on this side, and these three down here have tears here, here, and here on the left side. Okay? All right. Are you feeling better now? All right. Pain has subsided. Lay down. We're almost done. We're going to put you to sleep soon. And when you wake up, you'll be done with your surgery. Wouldn't that be nice? How bad is that on a scale of 1 to 10? Huh? 11? He said 11? All right, 11. I'm sorry. Is that where you typically get your pain? I know, but is that your typical pain area? Okay. So just lay still. We're almost done. We're going to put you to sleep. I promise you. So what are we doing here? We're doing what's called an evocative discogram. It's the only test in the world that tells you 100% whether a herniated disc is causing a patient's pain. And we just confirmed that this disc that we're going to be fixing today with a laser is indeed causing his pain, 100%. It's 11 out of 10 when we did the discogram. That's horrible pain. Obviously, he moves around every day, doesn't bend, doesn't lift, doesn't do anything, just lays in a couch because getting up just puts pressure on this disc and causes the pain to be activated. Same thing with this one. So I used a combination of a physical exam, having the patient point to the area where the pain is, combined with the MRI scan showing me there was a herniation there. But you never know for sure if that herniation is causing their pain until you get in the operating room and you do an evocative discogram. The other name for an evocative discogram is a provocative discogram. Okay? And so we did a evocative or provocative discogram. You better? Any pain? All right, we don't need to have a conversation. I just need answers from you right now, okay? I can't really hear everything you're saying. That's the problem. The anesthesiologist has got to relay what you're saying to me. What did he say? Are you comfortable? Okay. There. How bad is that on a scale of 1 to 10?
He hit with his hand.
Huh?
He said stop it, stop it.
I stopped. But how bad was it on a scale of 1 to 10? 13 over 10. Are you getting all these? That was L23. L2. I'm sorry. That was the one that you wanted me to cancel the surgery the other day so we can come and fix this one. That was the one we added. So I'm glad. Good thing we did. He was supposed to have. Just relax. You're fine. You're fine. I promise you. Everything's going good. I like to confirm that what I'm going to do surgery on is actually causing the patient's pain. You know, and the only way to do that is with a discogram. You can see there's a giant tear in the back of the disc. You can see, huh? That's L23. Yeah. I mean, we were not going to do that one the other day. We were only going to do 3, 4, 4, 5, and then he said, I examined him in pre-op, and I said, all right, we're fixing the pain here and here, and he goes, well, what about the pain up here? And I said, we're not doing that high. And he said, it's hurting. And I said, how bad is it? And he said, really bad. I want to get it fixed. And I said, okay, let's go back and look at your MRI. So I looked at the MRI, and indeed there's a herniation here with a tear, annular tear and herniation, small disc bulge. So we added it on. We just tested it, and there it is. It's 13 out of 10. Are you okay? Are you angry with me? Is that a yes or no? He said yes. Why? Why are you angry with me? All right. Well, I appreciate the love. Now look at this next disc, 3, 4. You can actually see the bulging disc right behind the needle where it enters the tear, and it's on both sides. I'm sorry. All right, I did it quick that time. How bad was that on a scale of 1 to 10? 15? The numbers keep going up. All right, 15 over 10. And you could all see that and hear it. There's no joke. These discs hurt. And thank God we figured it out. Otherwise, he'd be living with this pain the rest of his life. Can you imagine a person living with pain like that from a herniated disc or a bulging disc for their whole life without ever getting it fixed? Well, guess what? It happens all the time. I go to Facebook all the time. Whoops, already did that one. And I see people on Facebook saying, oh, I'm in so much pain. What's wrong? I have a herniated disc. No one can fix it. And I'm like, we can fix it at Duke Spine Institute. And they think I'm crazy. They think I'm full of it. But we do it all the time. The problem is that 99.999% of spine surgeons don't know how to fix these herniations and get rid of the pain. But we do it all the time. Are you okay? Yeah. All right. How bad is that? How bad? 1 to 10. I didn't hear him.
How bad? 12.
A 12 out of 10. That was for L45. So, you want to tell me what pain numbers you have? Now we can put them to sleep. I want you to count from 1 to 100. You get to go to sleep. We're done torturing you. Just lay still, okay? What did he say? Your nose is stuffed up? All right, I'll let the anesthesiologist deal with that. I need my lead pulled up again. Okay? All right, so folks who have been watching, I'm going to do the lumbar first, thoracic last. Okay? Yeah, that's definitely better. Thanks. We have now gained access to 5 herniated discs with annular tears. If you want to know why we're fixing these discs, we're fixing them because the patient is having debilitating pain in his thoracic spine and his lumbar spine. We just confirmed that those bulging discs, they're small in the MRI, but you can see when the patient's laying on this belly, you can see them bulging out. You can see it on that lateral x-ray right there, okay, at all of them. The dye is actually wrapped around the back of the herniations. So MRIs are not great at looking for herniations because you can actually, they're the best test we have that's non-invasive. So non-invasive means you just lay in a machine and get the test, but to get a better test you do a discogram, but it's invasive. You have to stick needles in the disc. So we don't want to do that for most people. We just get the MRI. It's a great screening tool. However, the MRI never tells you if a disc is hurting. And people have all kinds of herniated discs that don't hurt. So 90% of herniated discs in the world don't get operated on because they don't hurt, right? I wouldn't operate on 90% because people have them, but they don't have any pain. And they have no limitations of function. So we don't do anything. We leave it alone. But the ones that hurt, they hurt because of inflammation in the tear. And that's what's happening to this patient. Lay still. You're doing great. We're going to start with the 3 lumbar herniations, then we're going to go to the thoracics. So we have just confirmed with an intraoperative, provocative, evocative discogram that this patient has horrible, horrible pain coming from these 3 discs. And the reason they have pain is inflammation. It is the inflammation in the annular tear. That is what we at Duke Spine Institute, me actually, Dr. Duke Majan, discovered about 14 years ago. About a year into doing these, starting to do these, about 15 years ago I started. And when I started doing them, I was doing them for the hernia, right? The hernia that was sticking out, pushing on the nerve to treat radiculopathy. But I noticed the back pain always went away with the surgery. And that doesn't happen with a microdiscectomy. That doesn't happen. Just relax. We'll give you some more numbing medicine. That doesn't happen with laminectomy, microdiscectomy. It can happen with fusion. Lay still. That's just the medicine going in. Count from 1 to 100 out loud, please. Out loud, 1 to 100. Read off your numbers. Read off your numbers. Your discogram numbers. Come on. Yeah, never say T5, T6. That's what, like, people who don't know anything about the spine in the world, they say T5, T6. It's T5 hyphen 6. T10, 11.
Yep, 11 out of 10.
Good,
Lumbar 2 to 3, 13 out of 10.
good,
Lumbar 3 to 4, 15 out of 10.
good.
Lumbar 4 to lumbar 5 is 12 out of 10.
Perfect. And all of them are concordant. So right next to each one, concordant. Concordant means it's his typical pain. Is he asleep yet?
Okay, he's out.
All right, good. All right, so I'm going to advance the dilator through the foramen at L23. You can see it on the x-ray machine. Are you getting the x-ray views there, Diego?
Yes, sir.
Good. I want you to also notice, folks, this is bloodless surgery, okay? If I say bloodless and he loses a drop of blood, you're all going to say you're crazy, you're lying because he lost a drop of blood. Here's how much blood he lost. Everybody see this? Now, why is there two colors of blood? Is that arteries and veins? Because veins have blue blood? Heck no. This patient bleeds Duke Spine Institute blood, blue blood. You like that? The anesthesiologist is laughing. All right, all blood is red, okay? The blue stuff is the dye we use in the discogram to stain degenerated nucleus pulposus, which you're about to see, okay? But you can see the tip of the dilator in that x-ray is just touching the bulging disc at L23. A bulging disc is a herniated disc. It's all the same. It's just not a giant herniation. Look how big the foramen is here at L23. Big foramen, small herniation, but still horrible pain. This patient doesn't have leg symptoms. We're not doing this surgery for leg pain. We're not doing it for sciatica. We're not doing it for necessarily for weakness or numbness. We're doing it mostly for discogenic back pain that doesn't go away with anything other than fixing the disc. And the Duke laser disc repair is the procedure, the only procedure that actually cleans up the annular tear and debrides it. Because I was the first person to do it and the first person to publish it in the National Library of Medicine. So you can't find this Duke laser disc repair done anywhere else in the world. You have to come to Orlando, Florida, to our office and get it done. The good news is it takes 3 days. You fly in, you get everything done in 3 days. We have patients from all over the world that come. All right, we're inside the disc. All right, so I went through the tear. I'm in the middle of the disc. And now we're going to bring the whole surgery, folks. Can you see this? Diego?
Yes.
So this is not a McDonald's shake straw that ended up in the operative field. This is actually the tube that the whole endoscopic surgery is done through. Ugh. I'm going to have to do something about my lead. Let me redo it and rescrub. Okay? I'm just gonna redo it and rescrub. Is he comfortable? All right. Yep, no problem. Yep. I'm just gonna go ahead and I need new gloves and gown. I gotta just tighten up my belt a little bit. I've lost too much weight. We have any questions while I'm doing this?
No questions yet.
Okay. How could we have no questions from the audience? Are they just all experts at this type of surgery? Huh? Okay. If you want, If you want, you can look at me over here. Turn your camera to the right. Yeah, keep going. See me? Hi.
Yes, I
Okay.
see you.
So this is the lead we wear during surgery, spine surgery. And the reason, in the old days, it was one piece of lead, top to bottom. And it was on your shoulders, and people get neck pain after a couple hours of surgery. So somebody smart figured out, cut the lead in half, do a skirt, right? And that's what I've got, a skirt here. But my belt is too loose, and it's sliding down. So, and then you get a vest, like this vest right here. And then they came up with like this ultra lightweight. So that's what I've got, ultra lightweight, because I do a lot of surgery and I have to wear this stuff all the time. So this way I don't get neck problems and back problems. Are you ready, Freddie? So you want to watch a surgeon gown? Can you see me?
Yes, we can see you.
All right, so this is how we do it. My hands are still sterile because I didn't touch anything non-sterile. You go inside the sterile gown. It's pretty cool. We've never filmed this or showed this to anybody. And then you got to get your hand out without actually touching the sleeve, and you only go halfway out. And then your assistant, Luis here, will open the glove, and I got one glove in. So again, I'm not taking my hand out until the last second. You barely get half your fingers out, pop them in, ta-da, and I'm going to double glove. And the reason I double glove is, what if I get a tear on my outer glove, accidentally? Like, I'm working with metal, I'm working with a hammer, I could just get pinched and I could tear the outer glove. Well, I don't want my patient to get an infection from my skin, just in case there is any bacteria there on my skin. So I don't want the bacteria to go from my skin to the patient, so I double glove. All right, back to the surgical field. Are we ready? So we've got our dilator in position. Take a shot. I want to make sure it hasn't moved because sometimes it gets pushed out by the pressure inside the disc, so much inflammation. So we're going to put this tube down. Can you see this tube?
Yes.
The laser. And for our audience, I'm going to show them what we're going to do here. This is the endoscopic rig, okay? Only endoscopic surgeons know what that means. And I'll tell you right now, 99.999% of neurosurgeons have no clue what this is. I didn't have a clue either when I started because, I had completed my training at University of Florida in Gainesville, top neurosurgery program in the country with Dr. Al Roten back in the 90s and early 2000s. We had never done this surgery. Only people that used an endoscope were ENT and orthopedic surgeons to look at knees and shoulders endoscopically. So this is a new technology. It was introduced to me by orthopedic surgeons that started to apply it in the spine over in Korea and in the United States. Dr. Young, who's retired now. So this endoscope goes down the tube once I get the tube in place, and I can actually, back down here at the bottom, I can do surgery inside the disc through this tiny little tube. Okay, that's all that's needed. So all these spine surgeons doing big incisions and laminectomies and microdiscectomies, they're chopping your spine apart for no reason. We haven't removed any lamina, we haven't removed any ligaments, we haven't taken any bone out of the spine. We're going through a natural hole on the side. We've done no damage to this patient's body except for one little cut. That's it, and one drop of blood. This is the most incredible spine surgery. It will literally be what everyone does 20, 30, 40 years from now. And unfortunately, that's how long it takes for these stupid surgeons to pick up on new things that are good. They just don't want to. And we have the companies that sell all the screws and rods where you have to open the spine. Those companies don't want this surgery to be known to everybody because they're going to lose billions of dollars in payments for metal implants, all the plates and screws and rods, because we're not going to use any screws and rods. You can see the dilator moving a little bit. I don't want that thing going in any further than that, so I'm going to pull it back a little, and then I'll advance if I need to shot. It's actually looking pretty good right there. I think that's it right there. Shot. Come on, shot. There's no way that's current shot. Shot? All right. So everyone watching the surgery, spread the word. I mean, all the fusions that are being done are completely unnecessary when you could do this. The problem is I can't compete with the marketing power of fusion companies. They have billions of dollars. They spend hundreds of millions of dollars. They've basically infiltrated all the organizations like the American Association of Neurological Surgeons, and they pay them $10 million a year to be a sponsor for their meetings. So those doctors and surgeons, they're on the boards of these companies. They get kickbacks, millions of dollars. And they're all like trying to teach the new generation of surgeons just to do fusions and stuff, artificial disc. And I can't compete with that because I don't have billions of dollars and millions of dollars to market, okay? And besides, I don't make any money selling any screws and rods. So I get nothing from teaching other surgeons other than that they get to learn this technology. So the truth is I'm happy to teach. However, nobody wants to learn because they all want to do fusions. They want to do fusions and artificial disc because they make much more money with that. And because there's a whole, you've heard of what's called the military industrial complex, right? It's all these companies that manufacture tanks and rifles and pistols and everything to do with our military. And they basically make trillions of dollars a year in government taxpayer money, and they're not going to go away. So they want war to happen because with war they get to build a government and make more money. Well, these companies that sell the screws and rods are just like the military industrial complex companies. They make billions of dollars a year on screws and rods. They don't want this surgery coming in. They don't want, just like the military industrial complex doesn't want peace, these companies don't want endoscopic Duke laser disc repair to be known. So I've had neurosurgeons who look at this and have approved it, but they don't promote it because they're making way too much money doing open surgeries. So that's what the patients are up against. And I can't tell you, I go to Facebook all the time and try to educate people about it. And there's just too many people to try to educate. So that's why we're revamping our website. We're going to use artificial intelligence to educate people. It's right there. And because I can't field all the questions, I'm just one man. We're a small operation. You know, we're a small company here in Florida. We're not a big company. When you come to Duke Spine, you actually meet me in person. I don't have other people yet doing my work for me. So there's only a couple of doctors here, Dr. Patel, Dr. Damola, a few primary care docs, and one of our fellows, and our staff. We have 65 employees, usually. They come to work, right, with COVID and everything, or unemployment checks. Fortunately, we don't have any of those kind of people. They all actually see work as an opportunity to help other people get out of pain. I can't do all this on my own. So my employees actually enjoy coming to work. But people are getting sick, really sick, and they're missing work. So not for any reason other than they're sick. All right, this is the tear we were talking about. You can see the crack right there. It's like a chasm. And all this scar tissue along the chasm, this is from inflammation, years of inflammation. So I've got to clean this tear up with the laser. This is called an annular tear debridement. I call it just for short annular debridement. This is what I do with this surgery. This is the Duke laser disc repair. There's no surgery in the world that does this except mine. Now, will other surgeons start doing it? Probably, when they learn what I'm doing and why and how it works so well. There's a piece of herniation right there. You see that? That piece of herniation is what's keeping the tear from healing. And that's why this patient has so much pain. And patients like him. Anybody with a herniated disc and back pain, it's due to the herniation of the nucleus sticking into the annular tear and not letting the annular tear heal.
We have a question from our app,
A question from where?
the Duke Spine app.
Okay. From the Duke Spine Institute app. Before I take the question, I'm going to just give a quick plug for the app. There is an app, folks. Anybody out there listening, there is an app available for free. Duke Spine Institute, we created it. We spent a lot of time on it. It is beautiful. Zach has been editing it and created it with me and my team. And it's got tons of really good educational content that will teach you a lot about what a disc herniation is, what facet syndrome is, what piriformis syndrome is, all common causes of back pain. And the app is free to download. There's no charge. And we actually use it in our clinic, so our patients who come here know that. We put their diagnoses, individual diagnoses that they have, into their phone on the app. So they have their own personal diagnoses they can leave with and actually look at it all later and look at it at home, share it with their spouse or friends or other doctors. So it looks like we have the ability for people to ask questions on the app. Stand by. Go ahead and tell me the app question.
What is the most difficult section to operate on?
What is the most difficult section to operate on? I assume you're asking about the laser surgery that I do. So the most difficult section of the spine to operate on is the thoracic spine. Now, C6, C7, and C7T1 are really, really hard too. I mean, probably the hardest, to be honest, because you got to go through the front, and the collarbone is there, and it blocks me from getting in a lot of times. So if somebody has like a short, fat neck, it makes it really hard to get into the disc through the front. So I would say a tie between C6, 7, C7T1 herniations and thoracic herniations. A tie, just because they're so hard to get to. Great question, by the way. And we're doing 2 thoracics today. And I gotta say, this is our first and 11th patient for thoracic herniations. He was the first one I ever did. He begged me to do his thoracic laser surgery. I had never done one. I was totally against it because I thought it was too dangerous at the time. I had never, of course I pioneered the cervical, I pioneered some of the lumbar technique, but the basic approach to the spine for lumbar I was taught, transforaminal. It was discovered by Parvis Camden out of Pittsburgh years ago. He's the first one to discover. Therefore, the Camden's triangle, which is an area, it's called the safe zone. It's an area inside the disc, inside the back of the disc, that's called the safe zone, or Camden's triangle. He was the first one to do lumbar transforaminal surgery, okay, way before me. And he developed the approach, going from the skin through the muscle to that area underneath the nerve root that's exiting. And so then it became more, not widespread, but there were endoscopic surgeons that started doing lumbar. Lumbar is easy, okay? Of the 3 areas, it's the easiest. Now, the hardest in the lumbar is L5S1, which we're not doing today. And the reason for that is the anatomy of the patient and the hip, the pelvis bone. All right, it rides high, and it makes your angle of approach to be steep. And so the facet joints are frequently arthritic as well. So they get bigger, and they move out to the side, and they push the needle away from the disc as you're trying to get in. So there are anatomical factors that make L5S1 very difficult. The endoscopic surgeons, there's only a few in the world. Those endoscopic surgeons that do lumbar surgery, they do lumbar surgery. They don't do cervical, they don't do thoracic, okay? So the endoscopic surgeons that do lumbar surgery, they avoid L5S1 and transforaminal. They go interlaminar, which means through the middle of the back. And interlaminar means you're removing bone and ligament to get to the disc. So it's not as good of a surgery either. You got to move around the nerve root and spinal cord, or thecal sac, I should say. And it's harder to gain access through the back, interlaminar. Interlaminar is a cop-out. I don't do interlaminar because it doesn't work very well. I do transforaminal L5S1. But most spine surgeons that do endoscopic, they won't even try L5S1 because it's so hard to do technically to get there, to gain access. But I do it. I've only had to abort about 5 of them in 15 years because of the anatomy, okay? So I've been able to do all the rest. And that's literally hundreds and hundreds and hundreds of them. So I'm pretty good at it now. I will tell you technically it's the hardest in the lumbar spine is to do L5S1. Look at this mass of scar tissue from inflammation at the back of the disc. And I've just got to clean all this up. This is the annular debridement. Right there at the tip is a herniated disc, and it's stuck inside the annular tear So the patient had trauma. The trauma caused the annulus fibrosus to rip. Hey, why don't you post our video, Diego, so people can watch our new video on why herniated disc causes back pain, okay? Why don't you run that
Yes, doctor.
and let people see what I'm talking about. The annular tear happens with trauma, and then the second step is the nucleus pulposus pushes through the annular tear from inside to out and gets wedged in there. And then it sets up a inflammation, an inflammatory cascade is called, where the annulus just became so angry and inflamed. It's just like sticking a thorn in your finger. You know, if you don't take that piece of wood out from the thorn, you're going to end up getting swelling and redness and tenderness and pain. And so that response is called inflammation. It's your body trying to attack the thorn and destroy it with its army. The army is the inflammatory army. It's like the Marines, okay? So the Marines are sent to go destroy that foreign body. And the inflammatory system is very good at killing bacteria, funguses, not so good at killing viruses, but good at killing bacteria and funguses, okay? Which is most of the invaders you worry about. But it's not so good at attacking metal shavings or wood, you know, and so you get this chronic inflammation because you can't get rid of that piece of wood that's still there, and it's just causing the body to react with inflammation. That's what's happening in a herniated disc that causes pain. The pain comes from your body attacking the herniation, the nucleus pulposus, because your body sees the nucleus pulposus as foreign. It's never seen the nucleus pulposus before. Okay? And the reason is, it's amazing, but the nucleus pulposus is located in the center of your disc, and it is walled off by the annulus fibrosus. Well, the inner half of the annulus fibrosus has no blood supply, no nerve supply, no blood supply. So whatever's in there, it's like in a vault, and your inflammatory system never sees it because your inflammatory system travels via the blood vessels. So if there's no blood supply to the middle of your disc, which there isn't, then the inflammatory system can't get there. So it never sees the nucleus pulposus. And it's like a bottle of bleach just sitting in the middle of your disc waiting to explode. And that's what happens when you get trauma. Trauma causes the annulus to tear inside out, and it allows this nuclear material to squeeze through. And when your inflammatory system finally sees it, it goes bonkers. And people get pain from the inflammation. It never stops until the herniation's gone. And again, I'm the one who discovered this, the first in the world. And we've been treating it with the Duke laser disc repair. But because nobody else understands it or understands the whole concept, they don't treat it. So they just think back pain is something that's not fixable. But it is. It's like the first time Wilbur and Orville flew. They understood the lift forces of air moving at different speeds across a fixed wing. They realized that the air that moves faster creates a lower pressure zone compared to the air that moves slower. And there's a force that's generated as a result of that differential in airspeed above and below a wing. And of course, the slower air that doesn't really move very fast, it pushes towards the faster air up against the wing, and it gives a lift force, okay? If you design the wing properly, of course. Or if you go the opposite way, it keeps a race car on the track by pushing downward. The point is, this whole field of aerodynamics came about because of one discovery about the properties, the physical properties of force with respect to airflow. And, you know, that's just one of many discoveries that humans have made. This is another that I've discovered. Okay, so unfortunately, most doctors have no clue about this discovery, and that's why we're trying to get the word out to people so that they will start talking about it. And, you know, it's one thing, if you never fly in a plane your whole life, it's okay, you know, you can drive. But if you have to live with chronic back pain or neck pain your whole life when there's an actual cure for it at Duke Spine Institute, you should get it fixed so you don't have to suffer your whole life. All right, that's really the message. Anyway, download the app, and it's free. It's for iPhone and Android. And we're going to be coming up with out with an update soon on the app because we want to reorganize some of the content and add. But any other questions?
Not as of now.
Okay. If you know somebody suffering with back or neck pain, let them know. Duke Spine Institute can cure it. We cure pain all the time. All the time. Every one of these surgeries has resulted in people's pain that they had in the disc going away. Now, it doesn't mean they don't have other causes of pain. Some people do. As a matter of fact, about 20% of our patients, 1 in 5, has other areas of the back that cause pain. So this surgery will only fix a painful disc. It won't fix the facet joints, which also can cause pain. It won't fix a piriformis muscle, which can also cause pain. It won't fix a bad hip joint, which has nothing to do with the surgery, that can also cause pain. So all the sources of pain have to be treated properly, and we're able to do that now at Duke Spine. And we're probably the first place in the world that's able to treat all causes of back pain successfully and cure it. But it won't all, they are not all treated with this particular one surgery. This only fixes painful discs. We've already confirmed this patient has painful discs with his discogram, which I suspected, of course, which is why I brought him to surgery. All right, I have cleaned out the herniation. I've debrided the annular tear. You can still see some inflammation there. That will go away now that we've done the surgery. But we are pretty much done here. This is all scar tissue, by the way, from chronic inflammation. We're done here. Laser off. It's beautiful, all right? You want to see the nerve root? The nerve root is right up here.
Wait up, 1 second.
Actually, it's in that blue stuff, so. All right, we are done.
All right, stand by, please. Yep. And then lights on, please.
Normally we can see the nerve root in the foramen, but we're so far below it you can't really see it. We're going to clean this out with a little betadine. Betadine is an antiseptic. It was developed at NASA, and it was developed for space travel, you know, protect the astronauts, protect the spaceship, space shuttle from bringing back any deadly viruses or organisms from other planets. So it's basically man's best topical antibiotic or antiseptic. It kills fungus, it kills bacteria. It's primarily bacteria and fungus. Okay? So 1 down, 4 more to go. Let me have that, please.
You can come, Jordan.
All right, leave that. I'm putting a little pressure here because when you put a tube or a dilator in someone's muscle and you come out, sometimes they get a little bleeding from a vein, a tiny little vein. No big veins, tiny ones. And rather than let it just bleed, we put some pressure, about 10 millimeters of mercury pressure, and that stops the bleeding. Let's see if our audience is astute. What if there's an artery that we nicked in the muscle and we come out? How much pressure will we have to put on the wound to stop arterial bleeding? Let's see who can answer that properly. Watch that. Anybody? Bueller? 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 Supposed to generate a laugh or two. My God, I think my team is tired or something. Shot. I need to see up there. You need to switch that to floral, please. Bueller. Okay, next is going to be the, I think, L34. Yep. Pressure. I need a third hand shot. That's perfect. So I'm taking the needle out, leaving my guide wire. I want to make sure the guide wire didn't come out, shot. Perfect. Now look, I'm going through the same incision, okay? Same incision as I did before. So I'm going to get 3 discs for the incision of 1. 1 7-millimeter incision does it all. Shot. If you're lucky and you get it right. Okay, So now we are at, we said 3-4, right? Yeah, 3-4. Okay, you can see the tip of the dilator, you take the pressure, is right at the back of the disc of 3-4. And I'm going to advance through the tear that's already there. We know the tear is already there. We saw it on the discogram. We saw it on the MRI shot. So I'm not damaging the disc right now. I'm not damaging the muscle. I'm not damaging the skin any more than I did with one incision. I'm not damaging the disc. This is the least damaging surgery for the spine in the world. There's nothing less invasive. Okay? Remember, the incision for fusion would have been this long with screws and rods. That's what everyone else is going to offer you, or artificial disc. And the artificial disc, you'd have to do 3 of them through the belly. That's massively risky, and they pop out, and they don't work very well at all because they don't really get the part of the disc in the back where the inflammation is from. So there's a lot of failures of artificial discs. That's why I don't do them. I don't recommend them, and I don't do them. I don't do them because this is 1,000 times better surgery than an artificial disc surgery. Now, you're not going to hear surgeons recommending this surgery because they don't know how to do it. And even if they did, they don't have the equipment to do it. It's millions of dollars worth of equipment to do this surgery. So they don't have the equipment, they don't have the training, and to be quite honest with you, they don't even know it exists. Because they've got their head stuck up there. You're supposed to finish that for me. It's all right. I think my audience got the image. Right, Rita? Have you ever met a surgeon with his head stuck up his? Yes. Yes.
Rita,
That's an experienced
so
nurse, folks.
standby light. So let's scope on.
Unfortunately, when surgeons run out of explanations, they blame the patient.
Lights off.
I see it all the time. They blame the patient for their ignorance, you know?
Very good.
And it's just the truth, folks. I don't need that. We're going in. Disc number 2, which is the, what do we say, 3-4? Ooh, that's ugly. Luis, I told you to give me this. Why didn't you give it to me? All right. If we don't get questions, we're going to have to put some music on.
Oh, yes.
Yes?
Yes.
Rita, did you learn how to put
Okay.
the music on? Did anyone answer my pressure for arterial bleeding question?
No.
No?
Mm-mm.
Shocking. Shocking. Well, the good news is I know this archive of surgeries will actually be valuable to somebody someday, long after I'm dead. That's when artists really get appreciated, is long after they're dead. How many people know doctors are artists? Huh? Have you ever heard the art of medicine? Right, Luis? The art of medicine. Well, how could there be medicine, art in medicine, if there's no artists in medicine? Of course there's artists. Doctors are artists. Some of them create nothing, and others create great works. Like Dr. DeBakey, right? First one to do open heart surgery. I think he was first to open, yes. You know, boldly going where no doctor has ever gone before. I mean, if it wasn't for pioneers in medicine, artists in medicine, where would we be? We would be so far behind. People would still be dying of infections. My God. How's my irrigation? Have you had to change the bag yet? You might want to keep an eye on it. It's looking a little bubbly. Thanks. Is our second patient here yet? All right. So one thing I'd like to try to work on is timing of getting patients here to make sure they're not waiting too long. How do you propose we do that? Yeah. Yeah. I definitely want them here at least basically an hour before we take them back. Man, this disc is so damaged. This is just a complete explosion or blowout of a disc. It's horrible. Can see all the degenerated nucleus staining blue with our dye. And just so much damaged disc here. So much. And all the pieces are just, I'm zapping them and releasing them and trying to get them out of here. This is a debridement. Hey, these are not herniated fragments. These are basically degenerated fragments that have been damaged, and they're now a risk of popping out through the annular tear and creating a whole new herniation or worsening herniation. That's the natural history of a disc injury, a disc herniation. You get an annular tear. Once that annular tear is made, multiple herniations can happen over time. And that's why we usually get, when we do a discectomy surgery, we get in there and we usually have to pull out like 5, 6, 7 pieces. That's because the disc is herniated 5, 6, 7 times. Okay, it didn't just happen at one time. It's usually a repetitive, sequential process that every time you do something, and it doesn't take much, by the way, a little bending, a little lifting, moving the furniture at the house, going out and gardening and putting mulch down. Those little bending and twisting activities can shoot out another herniation, because once you cause the damage to the disc with the annular tear, it's easy then to push pieces out. Okay? But it's not easy to push pieces out if you haven't damaged your disc. So the first thing that happens is the annular tear forms, and then the second thing that happens is you squeeze out herniations, little fragments of damaged disc, nuclear material, basically. It's called the nucleus pulposus. And those nuclear fragments of damaged disc, they get wedged into the annular tear and they create inflammation. And again, I am the first person to describe this. And we described it years ago. Years and years ago, about 14 years ago.
We have a question from YouTube.
Yeah, sure.
You apply pressure by pushing the artery against the bone, pressing down firmly on the artery between the bleeding site and the heart?
All right, so great question, or great comment. So the answer is, blood vessels are like these tubes, right? They carry blood, and they're under pressure. But the key is the pressure in a vein is very low. It's only around 10 to 12 millimeters of mercury, right? But the arterial pressure is 120 millimeters of mercury. So it's much higher. So it's like the difference between, if you've ever seen your neighbor like cleaning out their pool with that little blue hose and the water barely comes out, you can go step on that hose and very easily shut off the bleeding or shut off the flow with your foot. But a garden hose, on the other hand, or a fire hose, for example, that's under high pressure, you can't just put your foot on it like that and stop it from leaking. You got to put more pressure. So the arterial system is under a lot higher pressure than the venous system in the human body. Pressure of blood in veins is about 10 to 12 millimeters of mercury. Pressure of blood in arteries is around 110 to 120 millimeters of mercury. So basically 10 times higher pressure of blood in arteries. So you got to put 120 millimeters of mercury of pressure on the bleeding arteriole in the muscle to get it to stop. So the pressure you have to push is much higher with the bleeding artery, 10 times higher. It's a little bit of medical trivia. But hey, I appreciate you answering it. Man, this poor patient's discs are just totally damaged. Doesn't mean the surgery won't work. It's going to work. But boy, he has to really be careful with his back so he doesn't re-injure. Let me have a grabber. See if I can grab that piece out. So there's a lot of inflammatory tissue right there. Thing about inflammatory tissue is it's red because it's got blood flow. Right? What are the first thing you learn in medical school? What is it, doctor? Yeah, don't do harm, right? First, do no harm. All right, second thing you learn in medical school is inflammation has 4 key characteristics, and they're Latin, and they are rubor, dolor, calor, and tumor. Rubor, dolor, calor, tumor. Rubor, red, dolor, painful, calor, hot, and tumor, swollen. Those are the cardinal signs of inflammation. Every inflammatory process has them. So, red means there's lots of blood. Hyperemia, we call it. A lot of blood flow to that area that's inflamed. Calor, that area is hot. Okay? Whenever your body's inflamed with a virus, you're hot. You get a fever. But the reason it's hot is in inflammation is there's so much blood supply to that area, and blood is 98 degrees. So it's going to feel hot compared to other areas that are not hot, right? A lot of blood flow brings a lot of temperature, a lot of hot blood. So that's rubor, calor for calorie or temperature. Tumor is swelling, okay? We've seen swollen discs before. As a matter of fact, just this week, right, we did laser surgery on a patient with severely swollen discs. He was from Canada. And if you go back and look at those videos, you'll see how the nuclear material just popped out, like under pressure. Okay? So that's the tumor or swelling. And then finally, the most important for these patients that we're treating today, and with all of our laser surgery, is what? Anybody paying attention to me besides me? Sure. What was the one I haven't mentioned? The most important one, huh? What's the one we haven't talked in detail about is dolor, pain. Okay? People have back surgery because they're in pain. So yes, the inflammation in the disc causes swelling, tumor, redness, rubor, and hot area, calor, and of course pain, which is why they come to me for surgery, to get rid of their pain. So it's the pain part of inflammation that people want to get rid of the most. Okay, but you don't get to select what part of inflammation you're getting rid of. You either get rid of the inflammation or you don't. You can't just get rid of one part. All right? And medicines, like anti-inflammatories, they will go here and they'll work for a few hours and give you some temporary relief, but they don't fix the problem. Because the source of inflammation is never going to go away until you have surgery. And the only surgery really is the Duke laser disc repair. That's what you're watching today. That's what we do at Duke Spine. We are the pioneers, the creators of this technology, and it's the only place you can get it done. And the reason we were able to create this technology is because we understand the origin of pain in the back and neck. We know that it's from the disc, the injured disc. All right, let's see here. There's so much scar tissue here. And you can see how thick it is associated with the inflammation inside this patient's injured disc. Any more questions from our audience?
No.
Stand by. All right, we're almost done with this disc. And then we're going to do the next ones. We only want to take out what we need to. We want to leave as much disc as we can, as much healthy disc as we can, and let it heal properly. Irrigation good? We knew this would be a long case because we're doing 5 levels, and 2 of those levels are thoracic. Thoracic is really hard to do, but we actually got the needles placed pretty quickly. How's his oxygenation? Good? All right. Well, I feel very confident that my thoracic needles were placed well. We're not transgressing the pleural cavity. All right, let's see here. Luis,
Yes, sir.
you may need to score it. Let me have a grabber. See if I can get some of this stuff. A stripper. I didn't know we had a stripper here. This would be a good time for questions while we're playing with our laser fiber. Well, you can see all the inflammatory reaction of the tissue here. So much, I wouldn't call it a lot of bleeding, but because this is so magnified, it looks like a lot, but it certainly is more than we normally see. And the reason is because this disc is so inflamed. Come on. I'm using a technique to try to reduce. Look at all that inflammatory tissue. Can you pressurize that irrigation, please? I don't know that we have all the pressure we need. Any questions?
No.
How old is that one?
This one is, I have a new one.
There's definitely a performance drop off, you know what I mean?
Yeah.
All right, for those of you wanting to know more about the laser, we have a laser machine in the operating room, and it transmits laser energy from this one little piece here. It's just driving me crazy. It's one little herniation that won't leave.
Thank you very much.
The laser energy is transmitted through this glass tube or pipe, okay, down to the herniation. And I use my control of the glass tube to move it around and modulate the tissues, the pathological tissues, basically to vaporize them, destroy them, get them out of here. That's what I'm doing. I'm having a hard time rolling it. How is she doing over there, Luis?
Huh?
How is she doing over there? Miss Rita,
Oh, are you good?
sounds like you're struggling over there.
I'm just using that.
All right. I got to get some of this inflammatory tissue.
The suction is working?
Sorry about the poor visibility, but not much I can do about that.
Perfect. Thank you.
So the reason there's such poor visibility is there's red blood cells in the water. And red blood cells are, basically blood. And the reason there's more blood here is because we're at the outside of the disc now, where the most blood supply to the disc is. And I'm removing pieces of herniation. trying to pump out this stuff. Let me have the laser. So I'm getting rid of all this granulation tissue, which has little nerve fibers and is definitely causing a lot of back pain for him, right in the back of this disc. I'm getting rid of it all with the laser. But again, it's hard to see for you guys. So, but fortunately, I've been here before. I've done this a few times, so I know what needs to be done. And when they say you can operate blind, this isn't exactly blind. I'm still using visual inputs, but it's pretty close, right? At least at certain moments, you could argue that you can't see everything perfect. But fortunately, the laser itself is so accurate and precise that the energy that's delivered is just at the tip. And as long as I can visualize the tip and what it's doing, I'm able to control the delivery of laser energy to the disc properly and still accomplish my goals, even though the visibility is not so good. Okay? Grabber. This is like a little fumarole. How's he doing, doctor? Any issues? Oxygenating, ventilating well?
We have a question.
Yeah.
How long will this procedure take to recover?
To recover? Hold on. Let me have a laser. He's going to take 1 hour to recover. 1 hour. He'll be up tomorrow driving. He could go back to work tomorrow. He just, you know, you have to not lift anything heavy. We have a 25-pound lifting restriction for 6 weeks. But he could go back to work tomorrow if he had a job to go back to, which I don't know if he does or doesn't, but yeah. So 1 hour recovery. We will send him home an hour after he gets out of surgery. As a matter of fact, we'll try to do a video for him, of him for you all to see how he's doing. Yeah, 1 hour. I'm done here.
Rita. 1 second. Lights on, please. Lights on.
Scope off.
Scope off.
So once again, we're going to put our antiseptic. We used to use Bacitracin in our irrigation, which was great for gram-positive coverage, but thanks.
I try my best.
No, you did everything right. It's all my fault. But the FDA got nervous about doctors using Bacitracin in irrigation. Actually, not irrigation, but intramuscular Bacitracin, which we don't do, but since there is muscle here, you could argue that it is. We do topical Bacitracin, which is just, as you see here, put pressure here. It's just in the irrigation itself. We're not injecting it into a muscle. But rather than take any chances, we decided to do what everyone else did, stop using Bacitracin. So instead we use this betadine, which is also a really good antiseptic.
Rita, we need a fluoro. Thank you.
All right, we have completed 2 discs in the lumbar. We're going to go to our third.
Thank you.
Our third disc is the bottom disc, L45. And this one was pretty painful. I want to say it was a 13 out of 10. Shot. So. Shot. Shot. Good. So again, we'll place our guide wire and take the needle out, leave the guide wire in. Shot. Okay, everything looks good. You can see the tear in the back of the disc here at L45. Big tear. This was a painful one. He's doing okay. And notice how the venous bleeding has stopped. Shot. I'm at the facets. See if I can advance it a little more. Shot. Yeah. So I need you to probably come off the pressure, but just be ready to come back on. But no pressure at this time. Shot. Shot. Let me see. Come off. Let me feel. Shot. The nice thing is all this is done with little tubes. Tiny, tiny little tubes. Shot. Making our way down to L45. Nice job, Luis. Shot. Just about done. Shot. Here it is. Take. Good. Come on out with the fluoro. So we're at L45 now. And this is our last disc we're going to do in the lumbar. Our patient has had horrible pain back here since he re-injured his spine. And our goal is to get rid of all that pain. And I expect it all to be 100% gone. Now there is one more herniation he has a little bit further up at 012. But I can't tell if that's causing him any pain or not. I don't think it is. It's small. So we're not treating it. We agreed to that ahead of time. But it's tiny, and I told him there's a small chance it will be a problem in the future. Any more questions from our audience?
No.
Nothing? No?
No.
Grab her. Bring this back a little bit. Let's have the grabber. So interesting. I mean, this is a longer surgery than normal, but normally it's a shorter surgery. It's just that this patient has so many discs that needed to be fixed. And we knew it would be a long surgery. We normally don't like to do surgeries this long because we're not under general anesthesia. We're under propofol sedation. So I don't like having people under propofol so long. But the patient's healthy and wanted to get everything done in one shot, so we agreed to do it that way. Great job, Jordan. So once I finish this herniation in the lumbar, we're going to move to the thoracic, and we're going to do his 2 thoracic disc herniation repair. Now, if you ask any spine surgeon in the world about fixing a thoracic disc herniation, they're going to tell you it's a major surgery and it's very risky, could die. We used to do open thoracic surgeries at Shands Hospital in Gainesville in my residency, and trauma patients or fractures or infected patients. So I'm well aware of how to do them. I've done them. They always require instrumentation, especially if you're reconstructing the spine from in the front. You're putting in cages. You're doing vertebral body corpectomies and cages in the front, and all of that type of surgery is extremely invasive and risky. So to avoid all that, we developed this technology of fixing the herniations with a laser endoscopically. And again, pioneered it with this very patient over a year ago, about a year and a half ago. And the only reason I did is because he had no other choice other than the major surgery, and he didn't want it. And I thought it was not inappropriate for him to have a massive thoracic fusion, discectomy, with small herniations that he had. Nobody would have offered him that surgery, not even me. So he agreed that he wanted to do the endoscopic, and I agreed to do it. And as a result of his bravery to move forward and do it, we now do thoracic Duke laser disc repairs, endoscopic thoracic surgeries. They're all outpatient. And again, he's the 11th patient I've done. That's a herniation right there. So it's all scarred in from chronic inflammation. Did you run our video?
Yes, I ran the video.
Has John responded to you about the DLDR video?
He said he will get it done today.
Huh?
He said he will have it done today.
All right. All right, it's 11:15. Well, we should be done by latest noon. I think 30 more minutes, most likely, will be done. Depends on how long this one takes me. It looks awfully scarred in the tear. This is all scar tissue right here, this white stuff. One thing that took me a while to learn is it's not you don't always enter the disc in the annulus based on your angle of entry. You don't always enter it parallel to the annular tear. Sometimes you're angled down, sometimes you're angled up, sometimes you're at the top of the tear, sometimes you're at the bottom of the tear. So you have to move the tube around and reorient yourself to make sure you can repair the entire tear and not just part of it. Look at all those pieces of herniation there I gotta fish out. Every time I put the grabber in, it just takes time away from the debridement. But sometimes you just have to put the grabber in and grab the herniations out. Yeah. All right. Did you have the surgeries on the calendar?
Yes, they are updated.
When do you put them on?
Put them on this morning.
Why would you wait till this morning? You're supposed to put them on a week in advance. Diego, you're killing me.
I didn't know when the times were set, so I set it up this morning when I
You didn't
officially
know
knew.
the times of the surgery?
Until this morning,
You
yes.
don't need to know the times of the surgery. Did we start the surgery at the time that it says we were going to start it?
No.
Why is that? Huh?
I don't know.
Why? Because surgery never starts at the time you say it's going to start. It all depends on how long it takes to do the surgery, the one before, and clean the room. It's impossible to predict that. And we don't sit there and wait for a time. What you need to do is you just need to put a rough estimate of what time it's going to be. Why do you think you may not have great viewership today? Huh?
Yeah, because of the scheduling.
Because you never put that there was any surgeries. Oh, that's a big herniation. People don't know then. They think we have no surgery, okay? You put it the morning of surgery, that's ridiculous. Ah. Oh no. Anyway, I want those surgeries listed a week in advance, Diego. You are the one responsible for that.
I will do that.
It's not such an easy job, is it? Jobs that make people think are usually harder. All right, just about done. This is once again is the L45 disc, and fortunately it's coming along nicely. Stand by, grab her. Done.
All right, Rita, lights on, please. Scope off. Thank you.
We have a question from Facebook.
Sure.
Is there anything you can do for a compound fracture of T11-12?
Anything you can do for a compound fracture of T11-12? Yes. You can have surgery, you can have a fusion. I can't do laser there, that won't work. But you need a fusion most likely if it's an unstable fracture. So if you have a compound fracture of T11-12, you need to see a neurosurgeon or an orthopedic spine surgeon, preferably a neurosurgeon for your own good. And then you need to, if it's a 3-column injury and it's unstable, you need to have surgery to fix it, okay? So fixing it would involve fusing it, possibly even going in around the side and drilling away the fractured bone and putting in metal titanium cage to support the spine. So that's really, I'd have to see your films, I'd have to know more about the injury, the mechanism of injury, how old it is, how it happened. But long story short, that's not a laser surgery fix. That's definitely a real fusion and reconstruction surgery fix. I can do those types of surgery. I've done them, many of them in the past when I did my residency, and I did a lot of trauma surgery as a resident. But that's not the main part of my practice. So I would recommend going to a university hospital nearby you where you live and talking to a neurosurgeon that's experienced in trauma surgery for the spine. If you're local, I'm happy to see you and talk to you, but honestly, you shouldn't be walking around with an unstable fracture of the thoracic spine. I hope you're not. Okay, now we're at T1011. Can you, get me a better picture? I don't need an AP. A little pressure here, Luis. That's pretty good. Let's see it. Yeah, that's good. Uh-huh. So we're going to start the T1011 right now. We got our guide wire in. I'm bringing out the spinal needle I used to gain access to this disc. Making my incision. And we're going to use a 4mm scope. So I only need a 4mm incision. Okay? That's literally the tiniest surgical incision you'll ever see in your life. 4mm to access the spine. It's the smallest endoscopic incision possible. I'm going to bring my spiral dilator down. Okay? And again, we're going transforaminal shot. Trans means across, foramen means the neuroforamen. Yeah. Why are my hands sticky, you may ask? Because I just ate some cotton candy. Not. My hands are sticky because of the dye we use. We use a type of dye that is sticky. It's called Omnipaque. Lots of people use it in radiology. Shot. So I want to advance my dilator into the disc space through the tear, which is what I'm doing right now. Shot. See that? That's a good one. Was that because of the breathing phase?
Yes, sir.
So you didn't do anything, he did. Can't take credit for that one, huh? All right, so we are at 10-11 shot. Let's just get a quick AP to verify we are at 1011, T10, T11, because we want to make sure. We already did that, but I'll do it again. I want to look at T12L1. Move your hand. I got to see 12-1. So come south and shot. So there's the 12th rib, 11, 10. Let's rotate it one way or the other to get a little bit better, and then we're done. Yeah, come south a little. Yep. That's beautiful. There's a 1, 12, 11, 10. 10, 11. I verify, I agree. Go back to a lateral. Tube. So check this out. This is really cool. We're going to change the scope we're using. I would put a stitch. Okay.
Yes, sir.
Can you see this?
Yes, we can see it.
The whole surgery will be done through this little metal coffee straw. This is all FDA approved. This is the most advanced spine surgery in the world. Unfortunately, 99% of spine surgeons don't know how to do this stuff. So you're not going to get them recommending it. And the reason they don't know is it's new and advanced, and it doesn't involve metal infusions. And they just haven't been trained to do it. So I took it upon myself to learn. I went around the world. I learned from the early pioneers in endoscopic spine surgery. I was trained by them, and I learned how to do these surgeries. How is he? He's good? He's good? Okay. So, shot. I'm going to advance this tube down over the dilator, through the foramen, and into the thoracic disc. Shot. Shot. Don't try this at home in your garage. That's it. Done. Yeah, Louise. Yes. So cool, huh? Luis loves this stuff just like I do. All right. Well, can you see this?
Yes, we can see it.
The most esteemed, the most successful, the most pioneering surgeons in the world have never seen this ever. I'm serious. I say this because this is a time capsule, this video. It's capturing the first years of any spine surgeon ever doing this type of surgery. No one has ever gone transthoracic, transforaminal in the thoracic spine for herniated discs. These are not calcified discs. These are actually soft discs, and they're very painful. And the reason why doctors don't do this, it's very difficult technically to do, and they don't have the equipment, and they don't have the training. So don't expect your surgeon where you live to do this kind of surgery, okay? Because they won't. You have to travel here to get it done. And maybe 20, 30 years from now, doctors will be forced to learn how to do this because the insurance companies will stop paying. They'll stop paying for fusions for these doctors, these patients to get fusion surgeries. And hopefully this technology will be covered so people don't have to live in pain every day. But the thoracic endoscopic is a newer technology. In the 11 surgeries, why is the irrigation not going? In the 11 patients I've done, we've had 100% elimination of thoracic pain, back pain. 100%. Every single patient has had 100%. And we've had 0 complications to date. So it's safe, it's effective, but only 11 patients. So I think we need more numbers. We're going to get them. But for me to be able to really say for sure it's safe and effective, I need probably 20 to 25 patients.
Yes.
So we're not far away. All right, so this is I have too much exposure. I need to bring the light down.
Rita,
Bring me down 2 clicks. 2 clicks on the brightness.
Yep.
One more. All right, that's good. That's good. So a piece of herniation right there. I just want to focus a little better. And you're not going to get the same picture with this scope because this is a fiber optic scope. It's not a rod lens scope. There's a piece of herniation. Come on out. Fiber optic scopes don't have quite the resolution and picture quality as a rod lens scope. Okay, the lumbar scope is a rod lens. This is the cervical scope. I did not design these scopes. They're made by Richard Wolf. All right, I need about 20 minutes. We'll be done. Okay, doctor? Is he okay? Is he all right? I can't hear you. Is the patient good?
Oxygenation just drifted from 97 to 96. Nothing significant.
Do you hear lung sounds on both fields? Yeah, because we haven't gone through any new incisions. We went through the same one we went before that we established it was a safe path. But let me know. All right, Louis, stay with me.
Yes, sir.
I want to try to, you can see the tear. Okay, I'm working on the tear right now. And the blue stuff is the herniation inside the tear. And once again, we're able to get this treated properly with the laser. Again, another herniation. And you can see how smooth these are. Come on. Okay? All right, good. You see the piece of herniation coming out, doctor? Taking it out, floating it out. We call it floating. All right. This is inside the herniated painful disc. You can see there's a lot of damage to the disc. I'm going to work both sides of the tube. That means I'm going to work the medial and lateral components of the tear and herniation. Yeah. You can see how the nuclear material was just wedged in there. The blue stuff is just wedged in that crack. And that's where the pain's coming from. Oh, another herniation. Beautiful, just floated out. Each one of these represents an incident. You know, another squeeze out, so to speak. It's like, you know, leaving a bottle of toothpaste open and then squeezing it a little bit, then squeezing it again. And every time you squeeze it, a little bit more comes out. Okay? Sometimes you squeeze it harder, you get more toothpaste out. Sometimes you squeeze it softer, you get less toothpaste out. But in the end, you have all these episodes of toothpaste squeezing out through the hole. And they result in an accumulation of toothpaste outside the toothpaste bottle. And that's what we're dealing with. And the reason these herniations are inside the disc now is because we shoved them in when we put this tube in. We put the dilator, we actually pushed the herniations back into the disc through the tear. And now we're zapping them away. There's no other tool in the world that could do this surgery, by the way. It's only the laser. No surgical tool can get this kind of debridement done. The only thing that would come close is a drill. A special type of drill. And for God's sakes, I'm not putting a drill near somebody's thoracic spine. Right, Luis? And even if I did, it wouldn't do nearly as good a job. It would do, at best, 50% of what the laser is able to do, at best. The drill. Another piece of herniation. He really crushed this disc pretty bad. Luis doing a great job helping me. Thank you, Luis.
We have a question from YouTube.
Okay, we'll take the YouTube question.
How do we fix the tear in the annulus?
Yeah, how do you fix the tear? You can't like close the tear with surgery ever. Nobody's been able to do that, and it doesn't work. So don't believe anything people tell you. But what you do is you clean this stuff out, and then the tear will literally heal itself. And it heals with collagen, which is exactly what the annulus is made from. It's made from collagen. So your body will heal this tear properly if you just get rid of these blue things that are stuck in there, which is what I'm doing with the laser. That's actually a herniation that I'm getting rid of. So it's a herniectomy, you know. It's not really a discectomy. It's called a herniectomy, technically. Yeah. So the tear will heal. You don't need to do anything. The only thing the patient has to do is not pick up anything heavy, not play any contact sports until it's healed. Otherwise, you push out another piece while the cap is being closed. Just about done here. Just about done. You can almost see the epidural space there at 12 o'clock, just behind the retractor. Little end plate bleeding. That would be T10. Right, it's 10-11, so that would be T10. Notice how I'm going back and forth. So I'm going from the medial part of the tear to the lateral part of the tear. I want it all to heal. I don't want this thing coming back. So I'm going to debride everything. Medial and lateral. Incredible. This surgery was never possible until last year. I mean, sure, it was possible because we had the equipment, but it was never done. And because the surgeon didn't know how to do it until last year. So I guess you could say it's still not possible until last year. Right? We had the anesthesiology to do it. We had, hey, I don't have much flow. Are you keeping up?
Yes, I am.
All right. Huh? This is, it just seems like the flow is sluggish. You sure? All right, don't pop it.
Yeah, don't pop it.
I'll check the flow in a minute when I get this out. We're just about done, and this is T1011. Yeah, this flow is super sluggish. Are you pumping the right bag? You may be pumping the wrong bag. All right, yeah, you got the wrong bag. Okay. Thank you. That's good. We're good. Don't pop it, whatever you do. I hate loud noises. All right. Just about done here. He's going to feel so much better after this surgery. All the hard work pays off. We are literally just lateral to the thoracic spinal cord at T1011. I'm literally just to the side of it. And there's the end right there. And this is all scar tissue from inflammation. So that's the spinal cord is going to be just at 12 o'clock. Of course, there's a covering over it called the dura. And all along the back of the disc, I've cleaned everything out. It's going to allow this thing to heal. I'm going to go lateral again. One more time. Get rid of this herniation. And this procedure is how you get rid of pain from a herniated disc. It's called the Duke laser disc repair. And by the way, it looks big, but the tube you're looking at is the side to side is like 3.2 millimeters. 3 millimeters basically. So it's not wide at all. It just looks big because it's all magnified endoscopically. It's like a game of Tetris. Just about done. Jordan, we got one more to go. Now the nice thing is we don't need any x-rays after surgery because we're not doing any fusions. We're not putting any metal. We're not doing a fusion. We're literally just repairing a disc herniation. So there's nothing to x-ray. Like with fusion surgery, you got to get pictures of all the screws and rods and cages and just about done. 10 more seconds here and we'll be done with this one. Again, this is the Duke laser disc repair, and right now we're doing a debridement of the annular tear from the herniated disc. That's where the pain comes from that these patients suffer with. And that should be it. That's now in the foramen. There's fat there. We're done. Just at 12 o'clock is where the spinal cord would be out, off.
Cup off, please. Lights on, please. Thank you. I think you just feel the linen without a needle.
We have one more level to do. It looks like we will be done at probably at noon. Again, that's antiseptic. Just don't want to ever get an infection. We've never had one from our surgery. We don't want to start today. Okay, so that was the T1011. Next will be T56, and that will be the last one. Let's get our fluoro in. And I'm going to show you when I'm done here all these, actually three incisions that we had to make, just three. One is 7 millimeters, and another is 4 millimeters, and the third one is 4 millimeters. So combined 13, 14, 15, 17 millimeters. We've repaired 2 thoracic disc herniations that are about 12 inches apart, and 3 lumbar herniations with 17 millimeter incision. If you go get a microdiscectomy with the least invasive microdiscectomy and just do one disc, you're looking at 21 to 25 millimeter incision. So almost twice as long as all the incisions added up with the Duke laser disc repair to fix one disc. And of course, open surgery, your incisions are going to be measured in multiple inches. So this is the least invasive spine surgery to cure a herniated disc pain in the cervical, thoracic, or lumbar spine. Okay, you can see one incision is here. That's the one that we did the 3 discs in the lower back. We just did the thoracic disc through this tiny incision. And now we're going to do our final thoracic disc herniation, disc repair with at T56. Shot, is that it? Nice job. All right, very good. Let's take a look again. All right, so I need to see the vertebral body a little better. Try to get shooting down the disc plane. Can you see it? Because I really can't see it that well. Looks like both lung fields are full still. That may be a little better. Yeah, that's better. That is better, but still not great. Can we do anything to make it better? It looks like our WAG is off. Go further north if you can. Try to center that, and let's try to repair the WAG. Either way, you can see the guide wire sticking out. I feel safe to take this needle out. Shot. Definitely don't want to go any further than that. Shot. Can you do any better with those vertebral bodies? I think it's a WAG issue, to be quite honest. You may have to raise the fluoro just a little bit to get above his arm. And now there's the vertebral body above. You see that one above? Let's try some waggage. Figure it out. Maybe my side south. Meanwhile, I'll make my incision. Again, this is another 4mm incision. Is that it? I don't know. What can we do? All right, maybe. Are we on the arms at all? Can you check the arm to make sure the fluoro is not pushing on it? And maybe drop the fluoro an inch, see what happens.
Yeah, this is taking the
The arm board we don't care, but the arm we do. Is it on his arm at all? Huh. All right, I think your orbit's off. Why don't you bring my side up, your side down. That's better. That's good. It's not great, but it's good enough. Shot. Shot. In the foramen now. Shot. At the back of the disc, I can feel it. Shot. Going in just a little. Shot. That's getting in a little bit. Good. Good. Let's I need the driver. Just about done. We'll be done at noon. 10 minutes probably. Shot. Starting to go. Don't trust it yet. Shot. That's better. Take it. Take it. Shot. Just a little further and we're good. All right. Good. This will be our last disc. We've done 4. We've done a thoracic and 3 lumbars, and this will be our last one for today. And hopefully the last one forever for this patient.
We have a question from Facebook.
Sure.
Can
John?
tears actually regenerate new tissue? What exactly is the healing mechanism?
Yeah, so can a disc tear heal itself? The answer is yes. And most of the time they do. But when you get, in some people, and we don't know why, but they get that nuclear material trapped inside the tear and the tear cannot heal. And when that happens, I have to go in there and help them by cleaning out the tear to allow it to heal. The tear is, the annulus, the material the tear is in is called the annulus fibrosus. It is made out of collagen. And the body heals it after I get rid of this herniation. The body heals it with collagen. So basically, we want the body to heal the tear with collagen, but the tear is not able to heal simply because the nuclear material is wedged in there, preventing it from healing. Shot? Shot? That should be it. Take it. That looks pretty good. Yeah, I'm going to come to your side. Go ahead and go out. I'm going to switch sides, folks. Everything we've done so far has been on the patient's left. Now we're going to the patient's right for this last herniation. So once again, everybody asks me, can the disc heal itself? The answer is yes. The reason it's not healing itself in some people is there's too much of that nucleus pulposus, the herniation stuff, stuck in the tear, and the tear just cannot heal itself. So my job is to go in there and clean that out so the tear will heal. Now, if you just take the nucleus out, it won't heal because you have the annular tear that is full of scar tissue and stuff. So you actually have to clean up some of the annular tear to stimulate healing. That's how the body works. When you have chronic inflammation in an area and tissue, it won't heal properly. You've got to go get rid of the chronic inflammatory tissue. Otherwise, the other tissue, the healthy tissue, won't heal. So we're actually promoting the healing of healthy tissue by removing the grungy, inflamed, chronic inflammatory tissue, if that makes sense. I need to see that. I need you to turn that panel towards me, please. Pieces of herniation already. Thank you. That's perfect. Nice job, Jordan. Oh, yeah. Look at that. Red material on the herniation. That is inflammatory granulation tissue. There's a herniation right there. That's a biggie. Come on, get out. Let me have the grabber. So we're almost done. This is the last one. This is T56. T56. Yes. If that was a Terminator movie, it would be Terminator movie number 5-6. How many people have watched the Terminator movies? With Arnold Schwarzenegger? Huh? Some of the best movies ever made. Right? But a lot of the newer generation of people, they don't even know what the Terminator movies are. Did you watch the Terminator movies, Doctor?
Yeah, that's an old movie, right?
Yeah. Yeah, I mean, the original is old. Probably from the 80s. But the...
You have a new one?
Oh, no. I mean, I don't think they've had a new one in a while. I think 2000s, early 2000s. I forgot what number they stopped at. But we're doing T56 right here. So bring it. The T-series continues. I'm just getting delusional. That's what happens when I don't get enough coffee. All right, so this is the herniation, and the laser is not doing a nice job of cleaning it all out and cleaning up the annular tear. Well, you think little pieces. Just need my irrigation pressure to stay up. Is it the other way? Okay, next time. Well. I hear my patient snoring peacefully. It's nice that he can sleep and then wake up and all this is done. See the breathing? How the breathing affects the disc? You all see that? How every time he breathes, the blue stuff moves? See that?
Yes, we can see that.
You ever want proof of how Valsalva affects intradiscal pressure? Watch. That's him. So, pretty neat stuff. It's a great field. Oh, big herniation. Squeezed out. We call these reverse herniations, right, Luis? Oh, yeah. It's almost like the feeling you get when you've had a really good bowel movement. Just want to see who's paying attention. All right, which way do I gotta go?
To your right, to your right.
You help me. Swivel it.
This one, yeah, that one.
Yesterday, 2 days ago, Diego was watching me do a cervical fusion. And, let's go the other way. And he's like, wow, when I see the laser surgery done, comparing it to the fusion, it's amazing the difference. Now I see why you want to promote this technology. It's so much better for the patients. Yes, it is.
Yeah, it definitely is. With that, we have another question from Facebook.
Yeah, sure.
How does the Duke laser disc repair treat the issue of blood vessel and nerve ingrowth that typically results from disc bulging, herniation, and inflammation?
All right, I didn't hear the beginning. Something,
Oh,
how does a Duke laser disc repair? And then it got muffled. You got to just enunciate.
the issue of blood vessel and nerve ingrowth that typically results from disc bulging, herniation, and inflammation.
Who's asking such incredibly good questions?
Our viewer from Facebook, Bill.
Bill, nice to meet you, Bill, from Facebook. Great question. So, Bill is on it. The reason why these patients get so much pain in their annular tear is the ingrowth of blood vessels and nerves into the annular tear. Now, maybe Bill was watching my video we produced, but either way, Bill is now enlightened. It is those little nerves and blood vessels, not really the blood vessels, but the nerves, the little nerves growing into the annular tear in the granulation tissue that are really responsible, I think, for the heightened amount of pain you get with these annular tear herniations. So what the laser does is it goes in and literally cuts all that away, zaps it away, debrides it, cleans it out, just gets rid of it completely. And by doing that, it gets rid of the pain, because the pain signals come from those little nerve fibers. They're called free nerve endings. They're non-myelinated. They're pain fibers. They're what we call type 4 or class C fibers. And they're sitting there in that annular tear, just irritated all the time, irritated by the inflammation going on. So I remove the source of inflammation, which is the herniation. It's called the interposed herniation. It's the part of the herniation stuck inside the annular tear, causing all the inflammation in the annular tear. I get rid of the source of inflammation, and I get rid of all the nerve fibers that are growing into the annular tear with the laser. It just literally zaps them away. It vaporizes the tissue. It's like in the movies when you see this powerful laser beam or plasma beam, and it hits something and it just disintegrates it into a million pieces. I am standing in a fucking puddle of water. Why? Why is the water? Why is the water going down? Huh? I don't understand, Luis. Where is it going? What's the path? I thought I had it on my wrist.
No, it's right here. So
You gotta have this. Okay, that grabs the water and makes it go where the blue towel wants it, where you make the blue towel want it to go. Okay, that's the secret, is the blue towel. All right. I hope that answered your question.
thank you.
You can't see the little tiny nerve fibers, but they're microscopic. But they're in here. They're right in this area that I'm zapping away. We'll be done in 5 minutes. No stitches for the thoracics, just the lumbar.
Can you make sure we have micro to zero over here?
Yes, here.
Perfect, thank you.
Remember, the space we're working in here is 3 millimeters. That's the diameter of this tube. The internal diameter of the tube. The outer diameter of the tube is 4 millimeters. And the reason there's a difference is the tube wall has a thickness of about 0.5 millimeter on both sides. And it's steel, surgical steel. Anyone have a beach towel? It just keeps draining down on my... You got to follow the path of the water, Luis. Where's it going?
It's right there, sir. It just listen.
I can't watch it. Huh? No. No, look. Watch. If this goes past the opening into the bag, okay, then it creates a path. It doesn't matter how much you push it. It goes through the rag into the bag.
Gotcha.
I can't watch that and do the surgery at the same time.
Gotcha.
You have to watch that.
Yes, sir.
Sweet. This is all scar tissue. Just thick white stuff. It's just about done. Visibility is pretty good, actually. This is that giant tear, interposed herniation. Look at the crack of the tear opening with breathing. Beautiful. Look at the little granulation area inside, little pink stuff. That was cool. See the granulation tissue over in the blue to my right? You see it?
Yes.
That is where all the pain comes from. It's that nest of granulation tissue. I'm gonna go get it in a second. Sweet Jesus. This is so thick. See it right there? A little bead of granulation tissue. It's full of little pain nerve fibers. There, we're done. We're outside the disc now with the tube. I've obliterated the venom sac. I'm pretty much done. I just want to make sure I get it all right here.
Yes.
30 seconds.
Thank you.
Done.
All right, come off. Lights on, please. You can sit a bit.
I was hoping. Take this. I got it. We're done. Great job, doctor. Thank you. Really, really. No. Well, you've never seen anything like that. Have you ever seen a thoracic transforaminal endoscopic surgery? Okay, let me think. I got to take this out. Now, for those of you who want to follow my footsteps, I want you to notice something important here. For those of you who waited all the way to the end, you get a little pearl of knowledge and experience. Besides everything else I gave you, notice how the thoracic incisions are not far off the midline, whereas the lumbar are much further. Okay? So, lumbar incision is always almost where the body starts to wrap around, right there. And then thoracics are closer to the midline. That's because over here you don't have any paraspinous muscle, so you gotta actually have a narrower entry point. All right, we just did this patient's 5 discs, 4 millimeters, 4 millimeters, 7 millimeters. Luis, strong work. Strong work. Thank you. Scopes up top. Let's get these closed. All right, type up your questions for me, Dr. Duke-Majan, and I will gladly answer them for you. My team did an amazing job. We finished at noon, which is about the time I thought we would. This patient will be going home at 1 o'clock, probably 1:15, 1:30 latest. That's what I would expect. What is it? What?
Nancy Hauser.
Wait.
After the operation, it was totally gone. And so from my standpoint, my lifestyle is back. I stand straight, I have no pain. I go to the gym twice a week. I walk every day, and there's very few things that I can't do at this point in time, especially at 80 years old. I'm very proud to say that. I couldn't stand and hold him like this before the operation. Come on. I really feel great. I mean, well, before the operation, I could only walk up maybe 100 feet. I had to go back in the house. Now I can walk pretty much 2 miles every morning. In fact, they marvel at me at the gym that I'm able to do what I can do there. I'm kind of an inspiration for a lot of people at the gym. I still do all the maintenance of the house myself. I do the lawn, fertilize, I trim the bushes, I do the pool, I do pretty much everything. The fact that I can do this now is unbelievable. I couldn't walk, I couldn't lift a finger until I had the operation. It's easy to recommend to Dr. Duke and his staff up there because they're professional in every sense of the word. My operation, as I say, it was a big operation. And as far as pain medicine, I didn't have to take any pain medicine after the operation, which was significant because I'm allergic to pain medicine, which causes other problems for me. So I would recommend Dr. Duke and his staff without reservation. Come on. I really feel great. I mean, well, before the operation, I could only walk up maybe 100 feet. I had to go back in the house. Now I can walk pretty much 2 miles every morning. In fact, they marvel at me at the gym that I'm able to do what I can do there. I'm kind of an inspiration for a lot of people at the gym.
My name is Greg Spadaro. This is my father, Jack Spadaro. We are from Connecticut. We moved down here. For me, it's been about 20 years. I think my father's been down here a good 24 years now. And we've been two individuals that have kind of suffered with back pain and problems for a good portion of our lives.
My situation started back in 1964. I had an injury bowling, and it was not a serious injury, but someone at the time recommended me going to a chiropractor at that time. And I went to this guy, and I went to see him, and he ended up rupturing my disc. It was the first operation. It was a neurosurgeon in Hartford, Connecticut, named Dr. Scoville. And he did an excellent job, and for years after that I was fine, until I got here in Florida again, and my back problem started again. But we went up to Tampa. I had several laser surgeries done, which actually only aggravated my situation. And then locally we had a neurosurgeon here that became well respected as an excellent surgeon, and he operated on me twice. And my situation only got worse. I was bent over with the pain in my left side for a long time, almost 2 years. And then I heard my son telling me about Dr. Duke. And so I ended up going up to see Dr. Duke and explained my situation to him, how I was in such pain and such. And he took an x-ray and evaluated me, and he showed me on the x-ray how my operation actually had come apart. The fusion that they did locally here had come apart, and the nerve was being impinged on by